كما وعدناكم نبلش كمان شوية خلال دقيقة. طيب هلا بدنا نحكي cases، يعني حضرنا خلينا نقول 3 cases بس hopefully we'll be able to do them، يعني we'll try to do them fast. The first case is a patient with the wild type ATTR amyloidosis. So this is a 71-year-old Jordanian male. He was referred on the 29th of January 2024 due to suspected amyloidosis indicated by LVH observed on an echocardiogram. يعني في طبيب شافه عمل له echo ولقى في left ventricular hypertrophy. For some reason he suspected cardiac amyloidosis. بعت لنا إياه to the center. Patient had no symptoms. And this is important كمان to tell you, there are patients who may get the disease even without having symptoms. Early detection. His past medical history was significant for hypertension and بعرفش ليش طلعت هيك hypercholesterolemia. Interesting. He was on aspirin. باخذ antihypertensive medications olmesartan hydrochlorothiazide، ماشي على empagliflozin، باخذ lipid lowering therapy ezetimibe simvastatin، protein pump inhibitor 40 milligrams per day, and medications for his prostate. His labs were he had an A1C of 5.7, normal kidney function, sodium potassium were okay, uric acid was okay, total cholesterol, triglycerides, and hemoglobin were all okay. So on physical examination عندنا بالعيادة, he had, as I said, he was asymptomatic. His heart rate was 76 beats per minute, O2 sat was 99. As I said, we always take the blood pressure while the patient is supine. Please learn this, and you have to apply it to your patients all the time, especially in elderly patients, because you can have normal blood pressure while they're supine, but you can have significant orthostatic hypotension when you stand them up. So his blood pressure was 134/88 supine and 142/85 standing. So no postural drop in the blood pressure. His heart sounds were normal breathing sounds, and he had no lower limb edema. So this is his ECG. في evidence of low voltage طبعا، يعني بنحكي إذا lead 1, lead 3, AVR, AVL, maybe AVF كلياتهم they're showing low voltage، وحتى lateral precordial leads كمان show low voltage. ففي had some low voltage and also had cues in V1, V2, V3. So he had the pseudo infarct pattern that we talked about. Please, if you have any questions about anything I said, يعني please interrupt me, please.
Just take it for one thing.
Yeah.
The ECG, stuff, I think we learned that we have a good number of cases we don't see the low voltage. So at least I think it's at 30% of them they have normal.
Yes, so it depends on whether you're talking about AL or ATTR amyloidosis. In AL amyloid, in patients with AL amyloidosis have more low voltage ECG, in the range about 50%. بس إذا بتحكي على ATTR wild type, it's 30%, 25%, and even 10% will have left ventricular hypertrophy by voltage criteria. So not every patient will have low voltage. Some patients will have normal ECG, some patients will even have left ventricular hypertrophy.
And prognostically, so let's say that we have the pseudo infarct, we have low voltage, so is it an affect the prognosis?
I don't think so. I haven't seen data that supports the presence or absence of low voltage contributing to prognosis in these patients. However, if you have low voltage compared to a patient who has normal voltage, probably relates to the amount of amyloid fiber deposit in the area. So my suspicion is, yes, it may have some contribution to to prognosis in a negative ways. The more low voltage you have, the more amyloid fibers you have in the heart, and the worse the prognosis. But to my knowledge, I don't know if you've seen data. So, yeah, but it makes sense, you know. So this is. Can you play the echo, please, أبو الشباب؟ خايف أكبس من هاي أعرف. رجعنا على هو ما ببين من هون على فكرة. رجعنا على السلايد اللي قبليه. اسمه ايش؟ ولا مش موجود؟ أحمد. السلايد اللي قبليه بالله وخلي الفيديو يلعب. Let the video run, please. So this is the مشي الفيديو لو سمحت يا أحمد. مشي الفيديو. أيوة خليه ماشي خليه يمشي. So this is his. Remember, he had no symptoms, and on physical examination he was okay, but he had this amount of ventricular hypertrophy that was evident, concentric, and he also had thickening in the interventricular septum, كمان evident. And these are his echo parameters. Dr. هيثم حكى لكم شغلات كتير يعني. On the left you can see the thickness of the walls increased, the septum and the posterior wall. You can see evidence of diastolic dysfunction, very high E wave, almost absent A wave, and the E prime is very low. So this is significant restrictive, yani severe diastolic dysfunction, restrictive pattern, which is commonly the findings in such patients. And we did the PYP scan on this patient. And as explained by Dr. Haytham, شوفي يعني this is grade 3 uptake. When the uptake is more than the reps, this is grade 3 uptake. And if you look on the right side, the ratio, we always do the heart to contralateral ratio, هناك مكتوبة 1.9, so this is high. At 1 hour, 1.5 and higher is abnormal, so his ratio is 1.9. So everything pointing toward maybe ATTR amyloidosis. Very important point, we're never stop at a planar PYP scan. يعني هون بنطلع على القلب نلاقيه كله أسود. However, looking at this picture, you cannot tell is the uptake is the blood pool, يعني الدم نفسه لسه الراديونيوكليد موجود فيه, ولا this is true myocardial uptake. What we're interested in is true myocardial uptake. Planar images does not distinguish. So you never stop at planar images. You have to do, as was pointed by Dr. Haytham, you have to do SPECT. Then the SPECT is the only thing that can differentiate between true myocardial uptake or blood pool uptake. And in some centers, we don't do it in Jordan, but they do SPECT CT. I don't know, Dr. Haytham, if you do SPECT CT, but they do SPECT CT, and it helps in localization. So it's a CT image and a nuclear image PYB scan merged together. So it helps with localization. تقدر تعرف الuptake, is it in the septum, apex, posterior wall. It's very useful. But minimum you have to do SPECT. I don't know if this is positive or negative. I'm reading this as grade 3 positive, but still without SPECT I cannot tell. And this is a SPECT. إذا بتلاحظوا, this is الuptake is in the myocardium. هاي في عندنا الدونت بالشورت axis اللي موجودة فوق. الكافيتي which is inside is empty, ما فيها radioactivity, بينما الريم اللي حواليها كل الميوكارديوم is white, meaning there is activity. And in the long axis view اللي تحتيها بتشوفوا كيف إنه الuptake in the myocardium, and it's not in the blood pool. So this is a positive grade 3 PYP scan. Without the SPECT, you're in doubt. Okay, so always do planar and SPECT at the same time. في some issues in do it at 1 hour or 3 hours. أنا ودكتور هيثم حكينا مع بعض. We usually routinely do acquisition at 1 hour and we do it at 3 hours. Some centers they skip the 1 hour images and they just do the 2 to 3 hour imaging. But regardless, at the end, this is what you're looking for. So what's missing now? هي عملنا له PYB scan طلع grade 3 positive. What do we need to do now? Or what we need to do even before we do the PYB scan, or simultaneously at the same time we do the PYB scan. إيش؟ We need to rule out AL amyloidosis, صح? So always remember that. I have not established a diagnosis yet. Okay, without doing AL rule out testing, I don't have a diagnosis. So we do it either simultaneously or even before PYB scan. We also do cardiac markers, very important. In pro-BNP, our BNP, and we do high-sensitive troponin. Classically, they're both elevated in patients with cardiac amyloidosis. Both بيكونوا عاليين. High-sensitive troponin in this patient is 93. النورمال عندنا احنا is 26 in 95 percentile. So من 26 ل 93, which means انه اذا انا كطبيب مش خاطر على بالي اميلويدوز، بشوف هاي سنتروبونين على السي سي يو طوالي المريض هذا لازم يدخل with an acute coronary syndrome، صح؟ عنده الهاي سنتروبونين and I would probably cast this patient looking for coronary artery disease. To my surprise, the coronaries will be normal. So an elevated high sensitive troponin and an elevated BMP or pro-BMP are highly suggestive of the presence of infiltrative disease, not necessarily amyloidosis. You can see it in other things. pro-BMP 600 عالي بس مش كتير لأنه sometimes you see it in the thousands or even tens of thousands. It will be very high. فعملنا له طبعا rule out AL amyloidosis workup. ال FLC, the free light chain kappa was 21, normal. With LC lambda 19 was normal, and the ratio was 1.13. Remember, حكينا ratio between 0.26 to 1.65, so 1.13 is completely normal. Serum immunofixation, electrophoresis was negative, and 24-hour urine immunofixation were negative. I ruled out AL amyloidosis. خلاص. Out of the question, I don't even have to think about it. It's out of the window. Okay? With these three tests negative, the free light chains and ratio, serum, and 24-hour urine negative, I have 100% sensitivity ruling out AL amyloidosis, so I don't have to think about it. So AL amyloidosis is ruled out, and I have a grade 3 positive BOAB scan. What's the diagnosis? Come on. Fabry's disease? Diabetic cardiomyopathy? What's the diagnosis? TTR amyloidosis, ATTR amyloidosis, صح؟ ATTR amyloidosis. So what else do I need to establish? خلصت؟ شخصت ATTR amyloidosis. So the diagnosis is ATTR amyloidosis. قديش البرسنتج ان انا اكون غلطان؟ 0. So I'm 100% confident انه I have a diagnosis in this patient. Okay? Unless طبعا زي ما حكى الدكتور هيثم اذا المريض عنده recent acute myocardial infarction او عنده rib fracture او عنده toxicity certain drugs زي hydroxychloroquine toxicity مثلا, which gives you this picture. But in the absence of these factors, this patient had ATTR. So what do I need to establish more? شو بدي أعمل للمريض? Genetic test. Okay, because I have to know this is wild type ولا hereditary type to screen or not to screen the family. This is his MRI. أظن فيهم فيديو هدول يا أخ أحمد. إذا بتلعب لنا الفيديو أحمد موجود؟ لا ليش برجع قاعد؟ في فيديوز هون؟ Anyway, this is the MRI of this patient. You can see that there is left ventricular hypertrophy. Ventricular hypertrophy in different views, including the short axis view, very clear. تحت على الشمال, we can see some fibrosis, late gadolinium enhancement. We can see whitening of the myocardium, and you can see it also in the middle, but short axis كمان posteriorly or laterally. You can see كمان the presence of fibrosis. على اليمين الصورة الملونة هاي اللي حكى عنها الدكتور هيثم T1 mapping. So أو بسموه relaxation time. Typically, in patients with amyloidosis, it will be high, without giving before. This is native before you give the contrast, the gadolinium. We use this بالamyloidosis لأنه it's usually high, بزيد, and we use it to calculate the extracellular volume, which is an important thing. If you want to do a CMR, it has to be a complete CMR. لأنه مش كل الhospitals have the capability إنهم يساووا هذا الشيء اللي بنسميه tissue characterization. فأنت if you work in a hospital or you have MRI capability, make sure they also have the software that does tissue characterization, that does T1 and T2 mapping, and give you also the benefit of maybe calculating the extracellular volume. Okay, so we do that in these patients. In native T1 زي ما بتشوفوا تحت هنا, it's 1468 high. Usually طبعا the number is center dependent or population dependent, but usually around 1100 Dr. Haytham is the normal value. For 1400 is high. والextracellular volume بعرفش ليش الشاشة طالعة كبيرة قديش والله المفروض انها تبين. I think it was in the 50s, 51 for this patient. المفروض يطلع رقم تحت بس الشاشة طالعة شوية مش مظبوطة. الextracellular volume in this patient طبعا الهارت المصل is composed of two things, cells and extracellular volume, extracellular tissues, cells and no cells. Usually cells comprise about 25-26% of the total mass or volume of the myocardium. The rest, 75% to 74%, is extracellular. So when the extracellular, sorry, بالعكس, الcellular is 27%, the extracellular space is about 25-26%. So when the amyloid fibers deposit extracellularly, this extracellular volume will expand, will increase. And in patients with amyloidosis can get up to in the 40s or even in the 50s. So when we see an extracellular volume of 40 or 50, this is very typical of cardiac amyloidosis. So in this patient, it was high. Native T1 map numbers were high, and also the extracellular volume was also high. So as I said, ضل الجينيتك تيست عملنا له genetic testing, oral swab, and the genetic test was negative, so there were no clinically significant variants. So هون خلصنا التشخيص، وصلنا للتشخيص. This patient has ATTR amyloidosis, the wild type, not the variant. Okay? And as usual احنا بلد فقير، فيش عندنا امكانيات، فما بنقدر يعني نوفر للمرضى الادويه الغاليه جدا جدا جدا. عندنا دواء اسمه دايفلونيسال ابن حلال. اتس نون سترويدال انتي انفلاماتوري، زيه زي البروفين وزي الفولترين وزي هالشغلات هاي، بس له سبيسيفيك اكشن اون ذا ثايروكسين ريسبتور اللي موجود جوات التي تي ار بروتين. It stabilizes that receptor and it prevents the misfolding of the TTR. So it's a stabilizer. It stabilizes the TTR protein. And he was started on it في 5/2/24. سافر، حكينا معه. He had a follow-up بشهر 11 بعديها ب9 أشهر, and he was doing very well. He was compliant with his diflunisal at dose 250 milligrams by 2. His kidney function, which is because it's a non-steroidal, the only drawback, probably important drawback, is its effects on the kidneys. And some of patients with cardiac amyloidosis, especially if they have heart failure, they have compromised kidney function. So you have to be very careful when you use it in these patients. But luckily, his kidney functions remained stable. So did his sodium, potassium, and ECG still shows the low voltage, no change. We don't expect change. آخر follow up كان ب 15/10. حكينا معه تليفون. He was outside the country, عايش بكندا. And he told 15/10 يعني قبل نص شهر يعني. And he told us that he was doing very well, and he was still on diflunisal 250 by 2. So this is an example of a patient from the first time he presented until we got the diagnosis and started on treatment. في أي سؤال؟ طيب خلينا أحمد نحط الحالة اللي بعديها رقم 3. So now we will show you another case of TTR amyloidosis. This time it's someone with a variant TTR amyloidosis. No questions?
Just to make it easier for the wild, that used to call C9.
Yeah, the old terminology, it was C9.
All the 50, so it's 70 or 80, and all of that is like wild, used to be called C9. They have like it, so they can take it.
So yes, TTR wild type is mostly in elderly populations and mostly males. So ستات نافدين من الموضوع إلى حد كبير يعني. The majority of patients are males, and they're usually old males. It's a disease of all populations. But sometimes we see it in younger people. This is in contrast to this case that we will show you. So this is a patient with TTRV. He's again, he's a Jordanian man, 61-year-old, بدخن. Presented في July 2024 with 3 months of sensory neuropathy in legs. عنده numbness, كان severe numbness in his legs يعني ضايقينه. And also he described orthostatic hypotension. قال كل ما بوقف ضغطي بنزل وبدوخ كل الأمور هاي. And he had no diagnosis. يعني شاف زي معظم مرضى الأميلويدوسيس، شاف دكاترة كتار, seeing different physicians, including neurologists, لأنه كان عنده numbness, فهي saw neurologists, أكثر من neurologist, وكلهم ما حدا, nobody thought of amyloidosis. حتى he went, الزلمة is well to do, he went to a hospital in Germany for this, لأنه عنده polyneuropathy أو numbness in his legs, and they saw him and he had no diagnosis. he heard about us فهي came. برضه بالhistory was significant also for a history of spinal canal stenosis. أظن هلا لما نحكي spinal canal stenosis المفروض إنه أنتم تعرفوا إنه يعني إنه this could be connected to amyloidosis صح؟ And for that he underwent lumbar disc surgery قبل 4 سنين. وعنده had right carpal tunnel surgery 3 أيام before يجينا إجاني وإيده لسه عليها المربوطة يعني. So do these two things ring any bells? Of course. واحد بيجيني بsensory polyneuropathy عامل spinal canal stenosis surgery وجاي رابط ايده لانه عمل carpal tunnel. في واحد عمره 61 سنه زي ما حكى الدكتور هيثم carpal tunnel in younger people we can attribute it to jobs اللي بيكبسوا على الكمبيوترز كثير او كذا هيك بس in an old man relatively old لا 61 is young is not old 61 man you would have to wonder why. This is his ECG. The blood pressure was 114 supine, 114 after 3 minutes of standing. So he had no postural hypotension, at least in our class. So this is his ECG. Anybody wants to comment? Low voltage. يمكن cues في الانفيريور leads يمكن يعني lead 3 AVF يمكن بس الانterior leads are preserved ما في عندنا pseudo infarct at least in the anterior leads بس the main issue here is the low voltage. So this is his ECG. يمكن صورته خبرة هلا سوري الإيكو يمكن صورته خبرة هلا بالإيكو مبين واضح إنه عنده concentric left ventricular hypertrophy حتى الأورتيك valve is thickened maybe the mitral valve little bit thickened بالshort axis نفس الشيء good systolic function صح؟ يعني systolic function is not compromised هون فإذا بنحسب له الإيجكشن fraction تطلع normal والإيجكشن fraction by the way is very misleading in patients with amyloidosis لأنه زي ما حكى الدكتور هيثم حكيت أنا من قبل الcavity size تبعهم is very small because of the hypertrophy and the stroke volume is little so it doesn't matter what the stroke volume is they still have heart failure or symptoms and signs of heart failure pathophysiology. This is in the 4-chamber view كمان نفس الفايندينجز وتحت الجي ال اس this patient شو اللي بنشوفه هذا بالجي ال اس what do we call this apical sparing لانه الاحمر هو نورمال فالايبكس از نورمال او بسموه تشيري اون توب الايس كريم الابيض لما بحطوا عليه كرزه من فوق كله ابيض وحواليه فوقيه كرزه هيك حمراء او حبه فراوله او شيء زي هيك بسموه تشيري اون توب يعني اللي هو الكرزه فوق الايس كريم ف this is apical sparing so this is a GLS picture typical of cardiac amyloidosis ما بنشوفها بالشغلات الثانيه so this is very طبعا none of this is diagnostic يعني انا بشوف هاي الايكو I don't have a diagnosis from the echo and I don't have a diagnosis from GLS ولا من الMRI so none of these will make a diagnosis of cardiac amyloidosis they will help me but still they don't give me a diagnosis okay so his labs زي ما حكينا احنا definitely all the time we have to rule out AL amyloidosis his hemoglobin was fine the A1C was 4.9 he was not diabetic kidney functions luckily they were okay total cholesterol whatever anti-pro-BNP was 92.7 is that normal yes well high sensitive troponin was 2.9 remember حكيت لكم 26 so his labs his cardiac markers were fine عملنا له free light chain الكابا was 12 اللامدا was 11 the ratio was normal والimmunofixation urine 24 hour was normal with serum immunofixation were normal so AL amyloidosis was ruled out and I have signs على الإيكو إنه this patient maybe has cardiac amyloidosis so what's next ليش صوتكم واطي صيحوا ايش هو سكان PYP سكان صح nuclear طيب so what we're looking at مين بده يشرح لي اللي بنشوفه هون مين بيحب يحكي come on خلينا نطلع على الشمال فوق what do we see في uptake في الهارت yes is it grade 0 1 2 or 3 grade 3 لانه الابتيك is more than the rips هي بتشوفوا الريبس طالعين تبع المريض الهارت مبين اكثر Is this enough for me to say the patient has a positive PYP scan? What do I need? SPECT اللي هو هناك على اليمين. طلعوا بالسبكت الابتيك مبين انه بالميوكارديوم صح. الكافيتي of the left ventricle is empty, black. كل الوايت is in the walls. So this is SPECT positive. And if نطلع على التحت الهارت to contralateral ratio, this is at 1 hour was 2.06. The normal is up to 1.5. 1.5 and more is considered abnormal. So من كل هدول we have a grade 3 positive PYP scan. And by the way, هلا لأنه we're trying to detect patients early, بطلوا في ناس حتى هلا there's a move إنه even to forget about these grades. إنه just to report it as positive or negative the PYP scan. Even if I see the slightest uptake, myocardial uptake in a patient, this is abnormal. So in an attempt to detect cases with early disease, حتى a little uptake, يعني if I do a patient, I'm suspecting cardiac amyloidosis, and I see a little uptake, it doesn't have to be grade 3, what a grade 2, it could be grade 1. So any uptake now is considered abnormal. Certain centers, when they reported PYP scan, بطلوا يقولوا grade 1, grade 2, grade 3, either positive, ruling out amyloidosis, or negative, or positive, consistent or suggestive of cardiac amyloidosis. بطلوا في grade 1 and grade 2, and I think this is how things are going to be moving, going forward. There will not be grade 1, grade 2, grade 3. There will be either positive or negative. عملنا له طبعا we always do a family pedigree for these patients لما بكون عندهم يعني when we diagnose them. So this is the family tree of these patients. In black is the patient himself, born in 1962. He has 9 sisters, no brothers. Father and mother, they died of disease not related to amyloidosis, and he has a son and a daughter. Supposedly they're all healthy, but none of them came to be screened لأنهم كلهم عايشين برية الأردن. بس يعني at least talking to the patient, he said they were okay. Ideally, all of these who are alive, يعني خواته التسعة and his son and his daughter should be screened. إذا إحنا كان هذا المريض ATTV the variant type of cardiac amyloidosis. طبعا عملنا له إحنا in addition, عملنا له كمان Holter, وحكيت لكم أنا Holter is very important in these patients, and we do extended Holter. Sometimes we do 24, but sometimes we do 1 week or even 2 weeks, trying to see if the patient has any malignant arrhythmias. He did not have anything that is worrisome on his Holter image. This is his CMR showing left ventricular hypertrophy, and if you can see, T1 was 1400, and the extracellular volume, luckily we have the number, it was 43.7%. It was high. So كل شيء عم بيقول لي this patient has amyloidosis. So this is just the cine. We started him on tafamidis, اللي هو كمان stabilizer, 61 milligrams per day, which is the standard dose. وعملنا له genetic sequencing. So before we get the results of the genetic sequences, we know that the patient has ATTR amyloidosis, but we don't know if he has the wild type or the variant type or the mutant type. His test came back, he had a mutation in the V50 MET, or VAL50 MET, V50M mutation. This is a common mutation. It's actually probably the second most common in the US after VAL142E, as Dr. Haytham بصلحني. The V50 MET is the second most common mutation in the US, and it certainly is common around the world يعني. وفي منها 2 types، في زي ما انتم شايفين في early onset وفي late onset. اللي بيفرق بيناتهم هو السن. إذا المريض أقل من 60 بنسميه early onset, in which case the predominant features are those of neurologic features. So it's predominantly neurological disease. The V50M late onset, as in this patient, because this patient was older than 62 years of age, بيكون عنده mixed phenotype, which he had. He had polyneuropathy and he also had cardiomyopathy. So he had both. So this patient has the hereditary type of ATTR cardiac amyloidosis. He was started on tafamidis, follow-up ب 18-11. He was doing well, infrequent palpitations, no worsening in his neurological symptoms. He was still taking tafamidis 61 milligrams. كمان follow-up بشهر 8 السنة هاي. ال ECG still shows low voltage. كان عنده شوية orthostatic dizziness, increased foot numbness. Remember, when we give stabilizers, unfortunately, we're not reversing the disease. بس إذا بناخذ المريض مريضين زي بعض، واحد بنعطيه مثلا الدواء، واحد ما بنعطيه الدواء. اللي ما بياخذ الدواء الورسنينج تبعه بيكون هيك، اللي باخذ الدواء بيكون أبطأ شوية. Both will continue to get worse with time. لأنه we're just stabilizing the protein, but the stabilizer is not 100% effective, and whatever deposited in his heart and his nervous system will remain there. We did not touch it. But there will continue to be a production of abnormal TTR protein, but to a lesser quantity or amount than if the patient is on no treatment. So they will deteriorate, but the deterioration will be slower than patients not taking treatment. What we're hoping for and what is coming in the near future, هلا في على اللي بنسميهم يعني في silencers مثلا which prevent the synthesis of TTR protein, وفي عندنا ال depleters which clean remove deposited TTR proteins from the affected organs. So in the future we will have treatments that reverse the disease, but so far with the stabilizers we don't reverse it, and with the silencers which are available we prevent more production of the protein, but the already formed deposited protein will not be touched. So ب 25/8 he had some complaints. He was still in tafamidis. His creatinine was 1, blood pressure supine was 130, standing was 109, ECG as you see, and echo he had still left ventricular hypertrophy. نفس الصورة. Thank you. امتى احنا المفروض نخلص؟ في معنا time for one more case؟ زي ما بدكم. في time لسه؟ طيب خلينا نشوف والله الحالة اللي بعديها. Next. لا بدي حالة ال AL رقم 6 I think. فرجيكم مريض AL amyloidosis. هيك بنكون غطينا كل yes thank you. بنكون غطينا كل الأنواع. So this is a younger patient, 40. The fact that the patient is 40 years of age should make you more think of AL amyloidosis than ATTR amyloidosis if you are suspecting amyloidosis, because usually ATTR, even the hereditary type, is of an older population. Also, although we see it in this younger age group, بس لما بيجيني واحد male or female age 40 وفي suspicion of amyloidosis, it's more of AL than ATTR amyloidosis. So this man, he's from Iraq, presented September 2023, and he was doing well until 7 months prior to his presentation to our center, where he started complaining of dyspnea and exertion. So له 7 أشهر بشكي. He was told في العراق إنه عنده LVH وamyloidosis برضه هناك was suspected. He was started on anti-failure treatment, as you can see. بالعراق عملوا له PYP scan وحطوا إنه grade 0 uptake. We reviewed it. The quality was questioned, but it was interpreted as 0 uptake. عاملين له كمان CMR عنده LVH ejection fraction 46%, في right ventricular hypertrophy, enlarged left atrium, thickened interatrial septum, mild pericardial effusion, and he had some late gadolinium enhancement. The free light chain kappa was 15, the lambda was 103. And so the ratio kappa over lambda was 0.014, which is abnormal. So this is the first red flag. You know, I might be dealing with AL amyloidosis, but this is not enough. What I need to do is continue the workup and do serum and urine immunofixation, electrophoresis, and they were reported as normal من العراق. والانتي برو بي بي was 7000, قلت لكم احيانا بيكون بالالاف. احنا عدنا او انعاد مره ثانيه كان 6000 وشويه. His kidney functions were okay, and his hemoglobin was 13.9. On physical examination, his blood pressure was 113/82, no skin lesions. Remember, and I told you periorbital ecchymoses and macroglossia are two signs that you see in patients with AL amyloidosis, not in all patients, but we look for those. So we could not find any skin lesions and no macroglossia, heart no murmurs. He had +2 lower limb edema. This is his ECG. So again, the standard leads 1, 2, 3 AVR, AVL, AVF, he definite low voltage, and besides this I don't see any other abnormality maybe. His echo, again LVH, pericardial effusion. You see pericardial effusion in both ATTR and AL amyloidosis, but you see it more in AL amyloidosis. Pericardial and pleural effusions, ascites and lower limb edema is more common in these patients. So he had this left ventricular hypertrophy, which was كمان طلعوا massive LVH يعني كتير. يعني the posterior wall was 23 millimeters in thickness, too much. And he had grade 3 diastolic dysfunction. His left atrium was dilated, and he had this pericardial effusion. Again, more pictures for you just to appreciate what we see. His IVC was sorry.
So the only thing with the pericardial effusion important when you see in the echo, usually this is not a good sign.
This is not a good sign.
Pericardial effusion in cardiac amyloidosis is like pulmonary hypertension. So when there's pericardial effusion, they make the prognosis a little bit worse, and we have to be more aggressive. For this. So usually with cardiac amyloidosis, pericardial effusion, it's worrisome. So it's a worrisome system.
I agree. So when you see pericardial effusion, يعني زي ما حكينا بالAL amyloidosis, see more pericardial effusion than you see in ATTR, and usually يعني if you do a chest X-ray, you see pleural effusions with them, and sometimes you see ascites and كذا. This is a bad prognostic sign in these patients. Again, the thickness, you can see it. He had restrictive diastolic dysfunction, large E wave, non-existent A wave. So we decided we wanted to repeat the PYP scan because we wanted to make sure it was done the proper way. And lo and behold, it was between 0 and grade 1. You can see maybe على أول صورة هون إنه في شوية uptake. You can see the shadow of the heart. But certainly the uptake is less than the reps, so this is grade 1 at max. And you can see it in the lateral view, by the way. You can see the heart. So this is grade 1. We rate it as grade 1 uptake. And if you look at the images, Michelle, the SPECT, you don't see you don't see clear delineation of the myocardium. So this is between negative and grade 1. And the ratio at 1 hour, was 1.3 تحت هون. Say static at 1 hour, فوقيها مكتوب الراتيو. It was 1.3, so it was less than 1.5, which is the cutoff for abnormal. وصراحة ال PYP scan ال 1.5 really is can separate those with AL amyloidosis from those with ATTR amyloidosis. This is a study looking at the 3 different subtypes of patients: AL, ATTR wild type, and ATTR mutant. كانوا يسموه mutant, هلا بنسميه variant with a V. وحطوا الكت-اوف for heart to contralateral ratio. بنلاحظ انه لما when we say 1.5, when we draw the line, كل المرضى اللي عندهم ATTR amyloidosis بيجوا above ال 1.5. كل المرضى تقريبا اللي عندهم AL amyloidosis يجوا تحت ال 1.5. So 1.5 is a good cutoff for separation between AL and ATTR amyloidosis, and we use that number. So عملنا له احنا طبعا we always try to repeat tests. فعملنا له free light kappa 13. Lambda again was very high والratio was abnormal. His high sensitive troponin لانه ما كان معمول بالعراق عندنا له اياه, and it was quite normal. So according to the guidelines, so this patient طبعا we did the initial workup and we detected the presence of AL amyloidosis. So we're going to go that pathway. So the first thing that we do in these patients is do what? شو لازم نعمل هلا قبل ما نسكر العيادة ونروح على البيت ونخلص الدوام وننسى موضوع المريض نفكر بشغلات تانية؟ Call a hematologist. This is an emergency. Light proteins are toxic. They're toxic. They're directly toxic to the heart. So بالاي تي تي ار بدك هالقد تي تي ار بروتين حتى يعمل مشكله. بالاي الاميلويدوز بدنا هالقد because they have toxicity. They're toxic. They damage the heart and other organs. So we call the hematologist immediately. We say we have an emergency. We have a patient we diagnose with AL amyloidosis. We send the patient upstairs to the hematologist and they see him. And our staging for this patient was stage 2 based on the Mayo staging of 2004. So as I said, we referred him to hematology for further workup and further care. هلا بالاي ال amyloidosis, unlike ATTR amyloidosis, بالاي-ATTR amyloidosis زي ما حكينا, if you rule out AL amyloidosis, you get a PYP scan that is positive, you have a diagnosis. انتهت القصة خلاص. تحط ايديك بجيبك, you don't have to do anything more for diagnosis. بالاي ال amyloidosis, you still need a tissue diagnosis. I have to demonstrate إنه في عندي amyloid, AL amyloids in tissues. لازم. Before I commit the patient to treatment, I have to confirm that in the tissue. لازم. لأنه eventually some of these patients may end up doing bone marrow transplants, and this is a major procedure that has a high but a significant mortality and morbidity. So I don't want to commit the patient to this. Plus, this patient is going to be on chemotherapy. So I don't want to commit my patients to chemotherapy, and I don't want my patient to go for a bone marrow transplant unless I am 100% sure that what I'm seeing in the heart, if there's kidney involvement, what I'm seeing in the kidney, if there is peripheral nervous system involvement, what I'm seeing in the peripheral nervous system is actually due to AL amyloidosis. So unlike ATTR, with AL I need a tissue diagnosis. Remember that. We need a tissue diagnosis. So we go for biopsies. And we go for the most accessible, less risky biopsy. We do a fat pad biopsy. Then I can do it in 2 minutes under local anesthesia. We did the fat pad biopsy and it was negative. Okay, so the hematologists, they want a bone marrow biopsy for several reasons. One of them to rule out multiple myeloma, for example. So they did a bone marrow biopsy, and we send the bone marrow specimens, and usually it comes back negative, and it was negative. So the Congorid on the bone marrow biopsy was negative. The Congorid on the fat pad biopsy negative. شدينا شعرنا هيك عشان هيك نازل الشعر ناقص. But in spite of this, we said we should not wait long on this patient, خاصة إنه من العراق. مشكلتنا بالأردن المرضى اللي بيجونا من خارج الأردن بيجوا معه هيك يومين بده يقعد في عمان أو 3 أيام أو 4 أيام مستعجل بده يروح. فقلنا حرام, he is 40 years of age. So we decided to start him on therapy right then because of the urgency. We start him on the triple therapy of Cybor-D, cyclophosphamide, bertezimab, and dexamethasone. This is the triple therapy. طبعا في another fourth drug that can be added, but it's quite expensive. That's what we do with these. Daratumumab is another drug that is very good in patients with AL amyloidosis, but unfortunately زي كل الأدوية الجديدة سعره غالي. إجانا بعد شهر, سافر طبعا, يعني بيسافر وبرد برجع. بعد شهر he was still fine, ماشي حاله, ما فيش شيء يتغير كثير, ماشي على Plerinone, which is an MRA زي ما حكى الدكتور هيثم. MRAs في evidence إنه they're useful. 2 drugs are very good in patients with amyloidosis if they have restrictive pathology. الناس MRA, mineral receptor antagonist, والثاني SGLT2 inhibitors, في عليهم new data إنه they work. The other drugs you can give them, بس يعني they're just like treating heart failure. فإجا بعد شهر, طبعا أخذ السكند دوز. we wait 3 weeks and then on the 4th week we give the second dose. قلنا له still منيح انت اخذت اول جرعتين, يعني very good, يعني ما تاخرنا عليك, بس يا زلمه بدنا لسه we still need a tissue biopsy, we still need a tissue diagnosis. فطبعا احنا we're trying to stay away from an endomyocardial biopsy لانه we do it, we've done cases, يعني we do endomyocardial biopsies عندنا في السنتر, بس يعني try to get to a diagnosis before you go to an endomyocardial biopsy, خوفا لست انه يصير مريض عنده complication من البايوبسي. بس we did a gingival biopsy. This is our salivary gland biopsy. This is our third site of choice. بنبعتهم لعيادة ENT, بيعملوها ب5 دقائق under local anesthesia, باخذوا له جزء من salivary glands and we send it, and it came back positive. So the gingival biopsy in this patient came back positive. إذا ما بتطلعوا على الأحمر هون الإيسن, المايسن إيسن stain showed the pink acellular tissue, And when it was stained with Congo red on the right and seen under the polarized microscopy, you can see the bright green birefringence, apple birefringence colors or picture down, confirming that the patient has actually AL amyloidosis. So we know now, we have our tissue diagnosis. So we now feel comfortable and we have the right diagnosis on this patient. Before this, لو الgingival biopsy اجت negative, we would be committed to do an endomyocardial biopsy. So we sent this for the state of the art. The best test for this is mass spectrometry, because mass spectrometry you can have a scan of all different proteins that can be normal or abnormal. But it's quite expensive. We don't have it in Jordan. So we do immune electron microscopy, which is as good as mass spectrometry. And the immune electron microscopy result came back confirming that it was AL amyloidosis. So now we have a diagnosis. But this is the report of the immune electron microscopy. Down there it says diagnosis AL amyloidosis, and it was lambda restricted, consistent with the level of the lambda proteins in the. So he continued to receive the triple therapy with Cyber D, came back زي ما قلت لكم بيروح وبيرجع, came back for his 8th cycle. إذا بتطلعوا تحت اللامدا اللي كانت very high is now normal, حتى ريشيو صارت normal, down من 112 أو 120 down to 23. So he is a responder, and some people they don't respond to therapy. This guy, luckily, he responded to the chemotherapy because his lambda type went down significantly to normal levels. Besides that, everything else was okay, was the same, except فعلا he was doing very well. And we told him now, since he responded very well, his young age, that he may be a candidate for stem cell transplant, autologous stem cell transplant. فطبعا expensive وكذا هيك, he worked it up with the Iraqi government, but he subsequently had a transplant في 11/7/24. It went well without complications. And يعني آخر follow up I think كان ب 11/2/25. We recently contacted him I think and he was fine. الانتي برو بي ام بي 2000, الهاي سنتروبولين was down to 19. تذكروا الانتي برو بي ام بي was 7000 أو 6600 when we started. Now it's down to 2000. Well, high sensitive troponin is normal. ECG no change. He's still on anti-failure therapy. Follow up by phone ب 2/11 قبل كم يوم. He said he was doing well. So this is what we know about him. And thank you. في أي سؤال؟ إذا بدكم نخلص. إذا بدكم نحكي for 5 minutes بس عن التريتمنتس بنقدر. نحكي 5 دقائق. حط لنا آخر محاضرة. I promise you 5 minutes. إذا وصلت بعد ال5 دقائق So it's very important to know what we have, and we'll make it short. I'm not going to tell you everything, but I will tell you what's available and what you should remember. So زي ما حكيت يعني there are different ways of treating TTR amyloidosis. مش راح نحكي عن ال AL. So TTR is produced in the liver. We can inhibit production of the liver. ففي عندنا two types of drugs. في عندنا small interfering RNAs, patisiran وبوتريسران، انسوا اللي بالنص هذا ما بعرف شو هو. وفي عندنا الانتي سنس اوليغونيوكليوتايدز اسمهم، اللي في منهم الاينوتيرسين والامبلانتيرسين، اوكي. وفي عندنا stabilizers. اوكي the protein is produced بس to prevent it from destabilizing or misfolding في عندنا بسموهم stabilizers. في الدايفلونيسال اللي هو الاولدر one non selective، وفي عندنا التفاميدس والاكراميدس اللي هن selective ones ونيورو ones. وفي عندنا الديبليترز اللي they work on the already deposited protein in the heart and organs. بجوز two important things are the antibodies down below اللي لسه اسمهم العلمي ما فيش اسم تجاري لهلا PRX004 و NI006. So this is the يعني the armamentarium we have for these for treating ATTR amyloidosis. و number of studies is huge. يعني زي ما قلنا لكم الانترست بالاميلويدوسيس له 10 years or 10 to 15 years. So the studies that have been done since then are really كتار يعني. So what is diflunisal? Diflunisal احنا بنستعمله انه it's relatively inexpensive. Diflunisal is a non-steroidal drug. بنعطى for arthritis وشغلات زي هيك. بس it also has a specific character that it stabilizes the TTR protein. زي ما حكيت بالنص في الثايروكسين binding site, it binds to this site and it stabilizes, it prevents the breakdown of the tetramer, الأربع units, into monomers and becoming rigid receptors. So in this study, this was back in 2013, 12 years ago, there was evidence that it helps in patients with polyneuropathy. أخذوا 130 مريض, نصهم they randomized them to placebo, نصهم to diflunisal, they followed them up, and what they found, طبعا this is intention to treat analysis, بلاحظوا انه من 64 who were treated with diflunisal, 37 completed the study, في 27 they discontinued for various reasons, disease of progression, liver transplant, and other reasons. وبهدوك كمان 26 completed the study, 46 discontinued. What's important في البولينيوروباثي إذا بنطلع على كل البارامترز, those who received diflunisal did better. NIS, neuropathy impairment score +7, was better in patients who received diflunisal. NIS, neuropathy impairment score, lower limbs, was also better in those who received, without going into details. وفي شيء اسمه SF score كمان that measures functionality, was also at 2 years was better in patients who received diflunisal. Diflunisal works. It's not selective, but it works. The reason I'm saying this and emphasizing this is بتعرفوا احنا بالادويه دائما الشركات اللي بتعمل ادويه جديده بيحاولوا انهم يخلوا الدواء القديم ما بينفعش مشان يبيعوا الدواء جديد. Okay? So احنا poor countries of the third world ما عندناش capabilities, financial resources to offer these drugs, expensive drugs, to our patients. فأنا لما باجي بعطي المريض دايفلونيسال بقول له خذ استعمل هذا الدواء رخيص, بنجيبه احنا من تركيا, بكلفوا الشهر بكلف 10 ليرات 15 ليرة, يعني 30 40 50 دينار بليبي. أنا كطبيب am I ethically comfortable with this choice؟ يعني لازم لما بعطي المريض دايفلونيسال أحس إنه أنا مرتاح نفسيا, ولا أحس حالي إنه أنا والله عم بضحك على المريض, عم بعطيه دواء ما بيشتغل؟ لا, بالداتا اللي موجوده بكون انا مرتاح نفسيا انه الدواء بيشتغل, لانه in this study in polyneuropathy it proved انه to be better than placebo, so it is effective in preventing this. And also في عندنا from Boston Amyloidosis Center is a very famous center كمان, they did a trial where they followed up 39 patients with the wild type ATTR وعالجوهم for diflunisal for at least 1 year. The median follow-up was 3.2 years. And what they found when they looked at mortality, إذا بتطلعوا survival, in red المقطع, this is in patients on placebo who did not receive diflunisal. الأسود, those are those patients who did not receive diflunisal, وبتلاحظوا قديش المورتاليتي كيرف تبعهم نازل لتحت. So in 6 years, only 20% were alive. بينما those who received diflunisal, their mortality at 6 years, they were over 75% alive. So there's a big difference in benefit, mortality benefit between those who receive placebo versus. So diflunisal works. Remember that. The major problem with diflunisal is because it's a non-steroidal anti-inflammatory, and in patients with amyloidosis, a lot of them, they have renal dysfunction. You have to worry about renal side effects. So 14 patients out of the 39 discontinued diflunisal because of kidney issues. So that's the only thing we worry about. If the patient starts with an abnormal kidney functions, they're more likely to have worsening. If they start with a normal function, they'll probably continue to do it. But you need to follow that up. If they don't develop kidney functions, it's a good drug to continue for these patients. Tafamidis, which is the first drug introduced, is a stabilizer. يعني هو بيشتغل زي diflunisal, but it's a more selective one, which was tried in the ATTRACT, our ATTR's ACT study, 30-month study on over 400 patients. وجدوا إنه it reduced the all-cause mortality by 30% and also hospitalizations by another 30% or 31%. So it was very effective. وإذا بنطلع بالنص على indices of quality of life, the 6-minute walk test was, لاحظوا إنه 2 curves went down, which means what I said earlier, إنه both patients will continue to deteriorate سواء أخذوا دواء أو ما أخذوا. بس the deterioration بالأحمر in those who received placebo was worse than those who received tafamidis. And also in the Kansas Quality of Life questionnaire, نلاحظ إنه كمان those who received tafamidis did better. they had an extension study. They continued to follow these patients. طبعا اللي اخذوا بلاسيبو حولوهم على طلع كده دايفلونيسال حولوهم على التفاميديس they continued on tafamidis. فالكيرف تبعهم it went upward يعني معنى صار في تحسن but they never caught up with those who received tafamidis from the beginning. So tafamidis was مشكلته الوحيده بامريكا بنباع still بنباع ب 210 او 250 دولار بالسنه. البيتنسي will expire next year, which means انه اي حدا بيقدر يعمل الدواء, which means انه هو رخيص كثير على فكره. There are people who are making this drug at home. اللي شاطرين بالكيمستري بيصنعوه في البيت, هذا حتى في الستيتس يعني. اوكي؟ So it's probably الدرج اللي هلا حقه 210,000 او 250,000 دولار, when it becomes generic you'll probably buy it as cheap as aspirin ولا شيء زي هيك. هاي المونوبولي تبعت الفارماسيوتيكال كومبانيز, عشان هيك they become billionaires. So with long term كمان quality of life improved. هلا ال other drug اللي هو الأكراميدس, the other stabilizer, it works like tafamidis but it is more selective. على فكرة اللي اخترعوا من اثنين, اللي اخترعوا واحد أردني الهماشني من رمسة من شمال الأردن. He is behind the development of this drug, and it had the same benefits as with tafamidis. It reduced death, it improved quality of life in all terms. Even the cardiac markers improved, the anti-proBNP اتحسن. Very important, and I think we need to know this, إذا بنطلع على تحت على اليمين, تحت الجهة الثانية على اليمين, يميني انتم بكون شمالكم, أنا هون عندي على اليمين. في D, it changes the serum transthyretin level. هلا transthyretin protein is produced in the liver, and I think this is a very important point. إذا بنعطي stabilizer, we're not preventing the synthesis of transthyretin from the liver, صح? We're just making it more stable. Transthyretin will continue to be produced. With disease, without the stabilizers, some of that transthyretin protein will become abnormal. So, if we do a transthyretin level, and we can measure that by blood on these patients, بيطلع عندنا level معين, and it usually will be reduced because I'm measuring the normal transthyretin. I'm not measuring the abnormal, so it will be reduced. If I give a stabilizer, زي tafamidis أو diflunisal, I am preventing the degradation of the transthyretin protein, and therefore a level of the normal transthyretin protein will go up. So the level will go up. And this is what you see here. With acromidis تحت بالبردقاني أو الأصفر, بنلاحظ إنه الليفل ارتفع في البداية لفوق وضل عالي, بينما البلاسيبو ضل واطي. However, if I'm giving a silencer, يعني الدواء اللي prevents the synthesis of TTR protein from the liver, the TTR protein level will drop. So بالstabilizers it will go up, and this is what I want. Silencers it will go down. Two different things. Okay, pay attention to this when you review literature. So كمان هون صار كان في extension للأكراميديس at 42 months, showing the same thing. إنه benefit continued with this drug. Well, this just shows you إنه early increase in the level كمان can contributing to mortality. الأكراميديس is still not approved in the US. So the only stabilizer approved now is tafamidis. Okay, and diflunisal as an old drug. The FDA is looking at the files, and they expected to approve it, and they will approve it. I think the date is 26th of December. يعني الشهر الجاي it will be approved for use commercially. But so far it's not approved, but it will be approved. النوع الثاني حكينا على الستابلايز. النوع الثاني اللي هو السايلنسرز, and في نوعين زي ما حكينا, small interfering RNAs and the antisense oligonucleotides. بديش احكي لكم عن الباتيسيران, it's the old siRNA, بس اللي اجدد منه الفيتريسيران, which is now currently available and it's being used, tried in the Helios A study, first tried on patients with polyneuropathy, بنعطى sub-Q every 3 months, and if you look at the left side of the slide you can see that it was quite effective in assessing neurological changes. The NIS +7 score was improved. Quality of life assessment by QCCA was improved. And if you look at the changes in the serum TTR تحت, بتلاحظ إنه it dropped. مش طلع زي الأكراميدس. No, it went down, which is what we expect with silencers. So vutrisiran is available as a silencer. Vutrisiran is available. It's tried in polyneuropathy, and in this study, Helios B, it was also given to patients with cardiomyopathy. and it was also effective as shown in the slide without going into details. So we can use it in both cardiomyopathy and polyneuropathy. The big advantage is giving sub-Q and once every 3 months. So it's easy. هدول كلهم drugs لازم نعطوا under supervision. فالمريض لازم يروح على الطبيب وعلى المستشفى ياخذ الدواء. you can imagine انه كل 3 اشهر مش مشكله 4 مرات بالسنه، بس في ادويه بتنعطى كل 3 اسابيع او كل هيك، فبده يروح كل 3 اسابيع ياخذ الدواء. فالفيتروسيران او الانفوترا اسمه is also approved. الاينوتيرسين is an ASO antisense، بلاش نحكي عنه لانه it's not available anymore. الابلونتيرسين اخوه او ابن عمه او النسخه المحسنه من الاينوتيرسين. بالنيوروترانسفورم study in patients with neuropathy again it showed that it is effective. It's given sub-Q every 1 month. وفي هلا ongoing trial بالابلونتيرسين اللي هي الكارديو ترانسفورم trial. It's the largest ever in patients with amyloidosis. أكثر من 1400 مريض انعطوا ابلونتيرسين placebo. They're being followed up. We expect the results to come out next year في August 2026 إن شاء الله, and it probably be positive. So in terms of silencers, we have vutrisiran available, and we should maybe next year have also eplontersen as an ASO available. CRISPR-Cas9 هدول بسموهم الجين editing, very important class of medications. So this is like a vaccine, okay? Usually our drugs work on the RNA or outside of the nucleus. بس هون احنا we're editing the DNA inside the nucleus of the cell. So what's happening with the CRISPR-9, we're introducing a molecule that had a DNA sequence that is normal and a scissors مقص بندخلهم مع بعض على النيوكليوس, بيروحوا على الدي ان اي المقص بيقص من الدي ان اي اللي موجود السيجمنت اللي مش نافعه بقيمها وبروح بحط السيجمنت الجديده. ف I'm editing the gene, I'm changing the gene from an abnormal gene to a normal gene, and this is called Cas9, and it is a one time in life therapy. So المريض بيحتاج بس جرعه واحده بحياته and the patient will be cured. So it's being tried in patients with TTR amyloidosis. يعني ان شاء الله الريزلتس تكون كويسه without going into too many details. بس المشكله الوحيده انه recently الستاديز اللي ماشيه مع الانتيبوديز. So this is CRISPR-Cas9. هلا في كمان في drugs antibodies that work by attacking the already deposited TTR proteins in the organs and breaking them so that maybe reversing the cardiomyopathy and the polyneuropathy. في two trials, magnitude and magnitude 2, واحدة في polyneuropathy واحدة في cardiomyopathy. They're ongoing. بس المشكلة إنه very recently, this is a week or a couple of weeks ago, one of the patients on the trial developed big rise in liver enzymes, so they had to stop recruitment. فهلا هدول studies are on hold pending the FDA approval أو يعني كذا. بس يعني these therapies are coming in the future. They're all ongoing trials. Do we have evidence in that we can reverse this? Yes. إذا بتطلع على هدول slides, this is using depleters. This is the same patient on the left side before treatment. طلعوا على ال PYP scan تبعه قديش positive. طلعوا after 12 months, almost from grade 3 to grade 1. Patient number 2, the same thing, from grade 3 to grade 1. And حتى إذا بنطلع على اليمين, إذا بنطلع على extracellular volume تحت, بنلاحظ إنه in patient number 3, كان الاكسترا فوليوم was 60%, went down to 42% at 12 months. والpatient number 4 كان 57%, went down to 40%. So is there a hope that we will be able to reverse the disease, not only stop producing abnormal TTR protein, but rather even cleaning it up and depleting the affected organs from it? Yes, I think the future supports that and supports the notion that TTR cardiomyopathy is a reversible disease. هدول مش مهم. So with the current available treatments and the ones in development, we're closer than ever to a cure, and thank you so much. بتحبوا نوقف ولا لا خلص؟ لا خلص خلصنا. في أي سؤال أو أي استفسار أو أي شيء ولا خلص؟ إيش ما سمعت مين؟ من هي يعني؟ طيب إذا هيك معناته باسمي وبالنيابة عن الدكتور هيثم، إذا الدكتور هيثم تحب تيجي تحكي لك كلمة. بنشكركم جميعا يعني على حضوركم، وان شاء الله ما نكون يعني زودناها عليكم. بس بليز يعني اميلويدوسيس زي ما حكيت مرض بده الواحد يفتح عيونه وأذنيه ودائما يفكر في الموضوع. احنا في الاردن جاهزين للمساعده باي شيء، يعني في اي شيء تطلبوه منا احنا جاهزين، وانا موجود في المؤتمر اذا حدا بحب ياخذ كرتي لسهوله الاتصال. فحياكم الله واهلا وسهلا، شكرا كثير لكم. صوره جماعيه يلا.